Great thing about revision is that it's your opportunity to fake being brilliant. I like to think not fake, it's your opportunity to actually being brilliant. So let's get started. So CNS, we will cover a few topics which generally get asked. In the embryology, most important topic, embryology and all the basics, the most important topic will be hydrocephalus. Then in seizures, febrile seizures, absent seizures. In disorders, very important, will be cerebral palsy, and the most high yield will be infection. We will have bacterial meningitis. Oh yeah, in seizures also status epilepticus management. Bacterial meningitis, or it's also called pyogenic, whatever. And then we have tuberculous meningitis, which is TB meningitis. So let's get started. So basics in neurology. So we have neural tube defects. You know that the central nervous system is made, the nervous system is made out of central nervous system, brain and spinal cord, and then the peripheral nerves. So how is it formed? We have a neuroectoderm which has a groove, neuroectoderm which forms something called a neural plate. The neural plate has a depression which we call a groove. The plate, the groove, and then it forms a proper pore which then is cut off from the plate, opening in the plate, and this forms a nice neural tube. Okay. The pore has an anterior end, a posterior end. The posterior end makes the caudal structures. The anterior end makes the cranial or rostral structures. Okay. So how common is a neurotube defect? A neurotube defect is more common than we would like. It's 1 in 1.5 in 1,000 live births. And if a mother, I'm sorry, this looks like something weird. Okay, 1.5 per 1,000 live births. And if a mother does have a kid with a neurotube defect first time along, then the chances increase to 3 to 4 times in the subsequent births. That's why gynac tie-in would be to raise the dosage of vitamin B12 to therapeutic dosage of 4 milligram per day. Okay. Now when does all of this occur? All of this occurs on day 24 to 26. What are the defects? Failure of closure of the neuropore is a defect. If this doesn't close, it would lead to, like, you can say spina bifida, myelomeningocele, meningomyelomeningocele, and stuff like that. Okay, or what causes this? So generally it's supposed to close. One of the causes why it doesn't close would be vitamin B12, sorry, not B12, 9, folic acid deficiency. I tend to confuse these two. Not B12, B9, folic acid deficiency, 1. Then drugs which ruin this, okay, so this will be valproate, these are anti-epileptic drugs, valproate, carbamazepine, phenytoin, and the rest. Now there are 3 other things I would like you to know for extra marks sake. So we have maternal diabetes, okay, which is overt and uncontrolled. What does this need? This needs, again, therapeutic dose of folic acid, which is 4 milligram per day. Then maternal diabetes followed by maternal alcohol, and a genetic defect in methyl tetrahydrofolate reductase. Okay, so the folic acid, we know it is used to convert dihydrofolate to tetrahydrofolate. Basically what happens is there's an addition of two hydrogen. This is a reduction reaction. Okay, which also uses vitamin B9. No. Okay, I'm not able to remember, but fine. An issue here in the methylene tetrahydrofolate reductase will also cause a neurotube defect. So now the types, like I said, if it is anterior, it is a rostral or cranial issue, and if it is posterior, it is a caudal issue. Okay, so if the brain or the cranium doesn't close, okay, it's pretty bad, and like this condition is called anencephaly, wherein there can be either absence of the brain tissue or there can be an open cranium. So we call it open calvarium and absent calvarium. Okay. So this could be complete or incomplete. So complete will be called holo anencephaly and incomplete will be called mero anencephaly. Okay. There's something called two more I would like you to know. One is encephalocele, wherein a part of the brain comes out of the cranium. And this part is most commonly the occipital or the posterior part. And one more is an encephalo. Okay, wherein there is a fusion of the occipital part of the cranium of the brain with the spinal cord. So the occipital end with the spinal cord is fused, and this gives the baby a stargaze appearance on USG along with a retroflexion of the head. Okay, so this covers the cranial end. Now we come to the caudal end, which is more common, more important. So the caudal end would have, we have spina bifida occulta hidden, then spina bifida cystica. Okay, in that we have two, whether the spinal cord is involved or not. If the spinal cord is involved, we will call it myelomeningocele. If it's not involved, we call it meningomyelocele. So now the caudal end, we have what we said. Now for basics, let's see. This is the vertebral column. This is the skin, right? And we have the spinal cord. So now what happens is, if we have a defect, failure of formation of one of the vertebral arches, this arch is not there. Fine. This usually occurs at L5, S1. We will have protrusion. We will actually have protrusion, but the thing is, the skin over here is covered. So what we see clinically is either be a tuft of hair here, and generally these are asymptomatic. So unless you find it incidentally on an MRI scan when the patient comes for some other issue, this is unlikely to cause any problem. Okay, so this is spina bifida occulta. It occurs because failure of fusion of one of the vertebral arches. The spinal cord protrudes outside. It's generally covered with a tuft of hair on the outside. Location is L5S1. It's generally asymptomatic. So that's a good condition. I mean, like, no symptoms means good. But we have the other condition like spina bifida occulta. Occulta was hidden. This is cystica, also called aperta. Okay, two types. Meningomyelocele. See, meningo is involving the meninges, and another type, meningocele. Again, myelo means the spinal cord. So here we will have the spinal cord protruding out from the defect. So in myelomeningocele, we have the skin here, we have the spinal cord here, and it is going to protrude out. Not the spinal cord, we have the meninges. Okay, so skin, meninges, and we have the spinal cord. So the spinal cord is not the spinal cord, again the meninges, sorry, I'm really sorry. The meninges protrudes out through the defect. Okay, there'll be a defect in the vertebral arches as well, there'll be a defect in the skin as well, and it will be seen visible grossly. Okay, this is going to be most commonly like L5, L6 only in the lumbosacral region. But the good thing, it has no spinal component. So it's going to be purely a cystic, brilliantly transilluminant, soft, fluctuant mass. Okay. Now we come to the not so favorable condition of myelomeningocele. Alright. So we have skin, and then we have, so what is this? This is skin, this is the spinal cord. Yeah, and we have the meninges. So here, meninges, as well as the spinal cord, both are going to protrude outside. Cool. So this is generally again in the lumbosacral region. And since there's a neural component involved here, we're going to see like element type of clinical features like decrease in tone, decrease in deep tendon reflexes. We're going to see flaccidity, and since it involves the lumbosacral region, we'll also see bowel and bladder incontinence. Now a very high yield point would be that there's something called Arnold-Chiari malformation. In the type 2 malformation, if present, 80% of the people with Arnold-Chiari malformation will be having a myelomeningocele. Okay, so that's it for the defects. So how do you diagnose it? Obviously, you can see it on ultrasound. You can see it on using markers. Markers would be the most sensitive is an alpha fetoprotein. Okay, so this is always raised in case of neural tube defect. But the most sensitive, most specific investigation happens to be acetylcholine esterase. So again, USG, 14 to 16 weeks, we can check for a neural tube defect. Most evident will be anencephaly. In that we have the star gaze appearance in case of INI encephaly, wherein the occipital lobe is fused with the spinal cord. Markers will be alpha fetoprotein, which is always raised in any neural tube defect. But this happens to be the most sensitive marker. This happens to be the most specific marker. Okay. Whereas management or like prevention with folic acid supplementation, like I said, normal dose is 400 microgram daily. So the normal dose, therapeutic dose will be 4 milligram per day. Okay, and if a mother does have, it's always suggested to take it preconceptionally, at least 2 to 3 months prior to conception. So that wraps up. We have a few other topics which I think we should not be covering. We'll just directly go to hydrocephalus. I think this much of basics is pretty good for neurology. Let's go directly to the most important topic here, hydrocephalus. So hydrocephalus is nothing but fluid retention in this. So normally we have a CSF which is created by the choroid plexus, which is then supposed to go through the Cavernous sinuses? No. Have to go via the dural venous sinuses and has to drain, right? It has to drain out. But when there is an obstruction or there's increased production, all of this will cause hydrocephalus. So normally what happens, pathway of flow is important. We have the lateral ventricles. The lateral ventricles have choroid plexus. This choroid plexus will create CSF. The CSF will flow to the third ventricle, and then via aqueduct of Sylvius it will go to the fourth ventricle. Aqueduct, go to the fourth ventricle. Foramen, then via foramen of Lashka it will come out to the subarachnoid space. It is drained through the villi. Villi reabsorb it. Okay. So this is the flow of CSF. Now, when do we say it's hydrocephalus? When the CSF volume is increased, which in turn increases the size of the ventricles. Okay. So the normally how much CSF fluid is there? In the kid it is 50 ml, in an adult it is 150 ml. So the type of hydrocephalus can be an obstructive type and non-obstructive type. So hydrocephalus, it can be obstructing or it can be non-obstructive. Now when obstructing means it is obstructing the flow, it is obstructing the pathway somewhere. So if it's obstructing the pathway somewhere, we're going to call it non-communicating. It is obstructing the communication somewhere. And non-obstructive will be communicating. I feel these terms are like non-notice just for confusing, but I think the meaning here is pretty clear enough. So in non-communicating, the most common type here would be aqueductal stenosis. Which aqueduct? Aqueduct of Sylvius, which connects the third and fourth ventricle. Aqueduct, okay, let's just write. Sylvius stenosis. We can have something called Danderwalkie malformation. We can have Arnott-Chiari, which I described over there is 80% of the time associated with myelomeningocele, which will have lower limb flaccidity, decreased tone, decreased reflexes. Along with this, we have vein of Galen. And then in the communicating type, we have two, where there's decreased absorption or there's increased production. So the increased production will be when who is producing it? The choroid plexus in the ventricles is producing it. So when there's a papilloma of the choroid plexus, or there's a decrease in absorption. This can be because there is who is going to absorb it? It's going to be absorbed by the villi in the dural venous sinuses, right, in the subarachnoid space. So when these villi are scarred, as in meningitis, or when these are obstructed, as in subarachnoid hemorrhage. Okay. So let's start with discussing these conditions. The first one, the most important one, the most common one would be aqueductal stenosis. So here we do something called so here the obstruction will be here. So there will be obstruction to the flow. So it is what type? It's an obstructive type, non-communicating type of hydrocephalus. So what we are going to do is something called a third ventriculostomy. So what normally happens is we're going to bypass the aqueduct. So the CSF is supposed to flow from the third ventricle to fourth ventricle. So instead of flowing through the aqueduct, we are going to give a tube to allow the CSF to flow, a tube connecting third ventricle to the fourth ventricle, such that the CSF can flow here. Then from the fourth ventricle, via the foramen of Lashka, can flow into the subarachnoid space and be drained out. So this is called ventriculostomy. It is done in aqueductal stenosis. The next form, the next kind of abnormality which can cause hydrocephalus is Dandy-Walker. So let's do that. So in Dandy-Walker malformation, what we have here is a defect in the roof of the fourth ventricle. Okay. So we have a defect in the roof of fourth ventricle. So this has a few associated features. Fourth ventricle absent means there will be cerebellar hypoplasia. There will be a prominence of the occipital lobe or the contents of the posterior cranial fossa, and it will show transillumination. Why? Because there's complete stasis of CSF over there. So this is Danderwalkie. Let's see if we can have a nice image of this. It's not bad. Yeah, you can see here we're having here cyst in the posterior cranial fossa. We're going to have no roof, enlarged fourth ventricle. There's no roof of the fourth ventricle. There's cerebellar hypoplasia. Okay, can we see this image? So like we said, we're going to have no roof. So you can see there's no roof here. There's supposed to be a roof here, which isn't there. So yeah, there's no roof. So what happens is the normal structure, cerebellum, is hypoplastic. We're going to have an enlarged fourth ventricle because it's having no roof, and then it might be replaced with a fluid like a CSF containing cyst, which shows transformation. So this is I'm so sorry about the pronunciation. I'm messing up things here, but it is dandy. And the second one just Walker. Okay, so we finish aqueductal stenosis, Dandy-Walker syndrome malformation, and the next one will be Arnott-Chiari type 2. So Arnott-Chiari has two types. We have type 1 and type 2. So in type 1, what happens is we have the brain here, the spinal cord, we have the foramen magnum. So here the tonsils of the cerebellum herniate through the foramen magnum into the brainstem. Okay, this is not going to have any hydrocephalus. Because there's no involvement of the fourth ventricle. So this is no use for us here, but just to know. Now Arnott-Chiari type 2. Okay, so herein what we have is we are going to have herniation of the vermis of cerebellum. And we're also going to have fourth ventricle involvement. So what happens if the fourth ventricle gets stretched? Okay, stretched. When something gets stretched too much, it's going to get narrowed, and this is going to call kinking or obstruction, which is just going to have hydrocephalus. I'm not going to mention it right again, but it's having the association of myelomeningocele. Next we have vein of Galen, and that's the last one. Yeah, vein of Galen, and that's pretty much all for hydrocephalus. So we'll be done with the first part. This is taking quite long. Okay, vein of Galen malformation. So persistence of the medial prosencephalic vein causes a dilatation of the vein of Galen, which increases the venous pressure, and this creates a high venous pressure in the right atrium, which can lead to a cardiac failure. Right. Again, I'm not able to understand this very well, so let's go to our let's see if we can get a good image here. Okay, I think I got a fair enough idea. So, in vein of Galen malformation, what happens is okay. So normally we have a good venous system, a durovenous system which is draining it, and we have an independent internal carotid artery, vertebral artery, circulovillus, all that stuff draining independently, right? So when there's an abnormal connection between these two things are going to happen. Okay, this is something called median prosencephalic vein or vein of Galen. Okay. So what is obviously going to happen? Arterial blood is going to flow into the durovenous sinuses, correct? So this is going to increase the pressure in the durovenous sinuses. In turn, it's going to decrease CSF absorption by the villi. And since DVS blood is also getting added up to the afterload of the heart, it's going to cause it's going to increase right atrial pressure, which is in turn going to increase right ventricular right ventricular pressure, which will in turn cause cardiac failure or right heart failure. Then, yeah, okay. So this is going to cause hydrocephalus as well as right heart failure, vein of Galen. So we covered obstructive or non-communicating type of hydrocephalus. Let's see what are the clinical features, what are the investigations, and what is the treatment. So clinical features of hydrocephalus will obviously be a big head. You're going to have macrocephaly. It should be head circumference greater than 2 standard deviation for age. Then a very good indicator would be increase in head circumference greater than 2 cm per month. A differential diagnosis of hydrocephalus must be in your mind. Then we have an increase in intracranial pressure, which would obviously cause papilledema. It will cause dilated emissary veins of scalp. It will cause a bulging of the fontanelle. And will cause a wide separation of the unfused sutures. Okay, on MRI we have something called a sunset sign. This is due to a dilated suprapineal recess, okay, which is nothing but compression of rectum of midbrain. So treatment, we have drug of choice, decrease intracranial pressure by decreasing production of CSF, use acetazolamide, which is a carbonic anhydrase inhibitor. And surgery would be a better option, wherein we have a VP shunt, ventricular peritoneal shunt, okay, or we could have a ventricular atrial shunt, either. I think this would be preferred in case of vein of Galen. Okay, ventricular peritoneal shunt, ventricular atrial shunt. And in case this patient ends up having meningitis, you don't need to do a lumbar puncture, instead you could do a shunt tap. Okay, so this covers hydrocephalus, which is our first topic. Now we go to, let's see how much time we got. 18 minutes. Wow, we're definitely not going to finish this on time. Let's go to febrile seizures, absent seizures, status epilepticus management. So what is a seizure? When you get seizure, first thing, definition. It's an abnormal paroxysmal neuronal discharge from neurons, which gives a motor, sensory, behavior, or autonomic manifestation. Again, abnormal paroxysmal nocturnal, I don't like the font size, paroxysmal neuronal activity or neuronal discharge, okay, which manifests as motor, sensory, behavior or autonomic dysfunction. Okay, so this is what is a seizure. This is a definition of seizure. For after definition, we are going to tell what is epilepsy, what is the most common cause. We're going to elaborate febrile seizures. Then we're going to talk about very important investigations, EEG findings, indication of lumbar puncture, treatment, prophylaxis. Then we'll talk about absent seizures. Same features, investigations, treatment, and most importantly, status epilepticus, definition and management. Okay, so let's get started. So we know what is epilepsy. It's abnormal paroxysmal neuronal discharge from brain which leads to motor, sensory, behavior, autonomic dysfunction. So when is this seizure called an epilepsy? When it is recurrent. That is, we have more than 2 episodes in a day. The most common cause would be HIE, hypoxic ischemic encephalopathy. And in older kids, we have febrile seizures. The most common type would be subtle seizure. I didn't know this was a type. I thought it was absent seizures, but let's see. Subtle seizures, and in elderly or older kids, we have GTCS. Fine. So now let's go with febrile seizure. So what is febrile seizure? Febrile seizure is a seizure which occurs between a very lovely age, 6 months to 6 years. So since it's febrile, it's obviously going to have a fever with a temperature of greater than 101 degree Fahrenheit with no CNS infection, electrolyte abnormality, metabolic abnormality, and no past history of afebrile seizures or trauma. So all of this is must to complete the definition of a febrile seizure. So did you get it? A febrile seizure obviously going to have a temperature of 101 degree Celsius, but you have to rule out 2 things. One, in the past, if there was any afebrile seizure, if there was any history of trauma, if there was any CNS infection, electrolyte abnormality or a metabolic abnormality. Okay, electrolyte abnormality, electrolyte infection, metabolic. Now what are the types? We have simple and we have complex. We have complex focal seizures, complex febrile seizures, and simple febrile seizures. Okay, this is duration is less than 15 minutes. It does not recur. And since it's simple febrile, this is complex focal, this will be a generalized seizure. And this will be a focal seizure. So we have this greater than 15 minutes and it will recur in 24 hours. Okay. So we covered definition, we covered types. So a few other variants we would say. When will this seizure become an epilepsy? If it recurs, right? More than 2 episodes in 24 hours or 1 episode greater than 30 minutes. There's something called febrile seizure plus. That is febrile seizure after the age of 6 years. 6 months to 6 years was at this one. So after the age of 6 years. Then GEFS plus, that is genetic or generalized epilepsy with febrile seizures plus an autosomal dominant family history of epilepsy. Okay, so generalized epilepsy with focal seizures. I think that much would be enough. So now we go to the investigations. What are the investigations we would do? Obviously the general investigation of CBC, sugar and calcium. And this is done in all kids who have a complex focal seizure or a febrile seizure. Second one we're going to do is, see, a easy way to remember this is just to rule out the conditions. Okay, so if you have any electrolyte abnormality, that's what we're doing. Calcium, we're doing sugar to check out infection, CBC to check out infection. We're going to do an electrolyte separately as well, that is sodium. In case of febrile seizure, we're going to do urine analysis. If we haven't been able to find a focus of infection, and then the three most important investigations, we have an MRI, we have an EEG, and we have a lumbar puncture. All three are important, all three are the most important takeaways from here, this seizure, apart from the treatment. So in MRI, what we get is, we have to do the MRI within 72 hours of a seizure. Okay. In EEG, we have to do it within 1 week. And a lumbar puncture has to be done only if the kid is less than 12 months of age and has not taken vaccine for strep and H influenza, strep pneumo and H influenza. If the kid is greater than 12 months and has been treated previously with antibiotics, and in any age where you are going to suspect meningitis. So this is the takeaway for the investigations. And the last, and I'm starting a lot of things here, but definitely treatment is the most important takeaway. If I've told anything before that, forget it. We're going to have treatment. So the treatment is going to be two things, actually three things. One, we're going to have prophylaxis. Apart from prophylaxis, we're going to have control of fever and then control of seizures. Control of fever, we're going to give paracetamol 10 to 15 milligram per kg 6 hourly. Per kg per day 6 hourly. Per kg per dose and 6 hourly. Okay. And we're also going to do tepid sponging to control the temperature. Then for the seizure, we're going to give lorazepam or diazepam or midazolam. So all of these are going to be different. Like, see, I really like to remember it this way. See, the best drug would be lorazepam. So we're going to give it IV, we're going to give it in the hospital, we're going to give it at 0.1 milligram per kg. The next best will be probably midazolam. So midazolam we're going to give again in a hospital setup intranasally. And the third one will be diazepam. So diazepam will be given per rectally in a community setup. Okay, so that's the treatment of seizure. And the prophylaxis of seizure would be two types. One, an intermittent prophylaxis, and other, a continuous prophylaxis. So intermittent prophylaxis would be given in case of a kid who lives far off, okay, who is having recurrent seizures of like greater than 4 per year and whose parents are anxious. What we're going to give is oral clobazam or diazepam. How much? Same. 1 milligram per kg per day. First 3 days of fever. Okay. So this finishes up intermittent. Continuous, when do we give? When it is bad, right? So when the kid already has febrile seizures, he's having he's having complex febrile seizures, he's having generalized epilepsy with focal seizures or focal seizures plus. What is plus? Is having after the age of 6 years, right? So what do you give here? Listen, for most of the child epilepsy, child seizures, the treatment of choice is sodium valproate. And how long will you give this? You will give this daily to the kid up until he goes with 2 years of no seizure episode. Then you can stop the drug. So that finishes febrile seizures. We have absent seizures and we have status epilepticus treatment. So in absent seizures, let's see how much time do we got? 6 minutes, not bad. So in absent seizures, what are the absent seizures? You can't tell the patient is having seizures. So it was called petit mal. Generalized tonic-clonic seizure is called grand mal. So this is like its small sister. Petit mal seizure. Onset, it is really easy to remember. So like school going, when the kids go to school, age 5 to 8 years of age. The clinical features include vacant stares, eye flutter, and unresponsiveness. So what are the risk factors? Stress and hyperventilation. But these school-going kids have so much stress and hyperventilation. Important is the EEG finding. The EEG finding shows this kind of, that is a 3 Hz spike and wave pattern. Treatment again, sodium valproate, lamotrigine, okay? I would also like to add ethosuximide, but let's see. So this is absent seizures. The next one is definitely a question. That is treatment of status epilepticus. What is status epilepticus? You already know the definition of seizure. You know the definition of epilepsy. A status epilepticus has a new definition. So we have T1 and T2. You should know that if the seizure lasts for greater than 5 minutes, it is an indication to start anti-epileptic medication. Okay. If the patient goes greater than 30 minutes, the seizure episode is greater than 30 minutes, know for sure they're going to be neurological sequelae. So, what is the management? So, kid is going to have seizure. Not a pleasant sight, but it's what's going to happen. So, as soon as the kid has seizure, what's the first thing that's going to cross your mind? Wait for 5 minutes. 5 minutes over, the kid's still having a seizure, start management. Okay, 1, 2, 3, 4, 5. First thing, ABC, airway, breathing, circulation should be secure. Oxygen saturation should be maintained greater than, if it is less than 92%, then we should maintain a mask oxygenation. Then head is turned to one side to prevent aspiration. Secure an IV line and prevent hypoglycemia. So, how is hypoglycemia prevented? When is hypoglycemia? When it's 54 milligram per deciliter. Remember, neonatal hypoglycemia was 45. Here, hypoglycemia is 54. What are we going to give? 5 ml per kg of 10% dextrose. If the seizure still persists, now come to the treatments. IV benzodiazepine. Still persisting, IV phenytoin or phospheniton better. Still persisting, so we benzodiazepine, phospheniton, we give levetiracetam. I'm pretty sure you know it, I'm butchering the pronunciation here, but then we have valproate, IV phenobarbital, And then it goes to refractory, where we give two things: continuous IV infusion and ketamine. Okay. Let's revisit this. So much more to add to this. So let's see. Now the kid is having 5 minutes over, kid still having a seizure. Let's go with our 5 points. Airway, breathing, oxygenation. Don't let the kid go into aspiration. Secure an IV line. Hypoglycemia prevented with 5%, 5 ml per kg, 10% dextrose. What is the treatment we're going to give? We're going to give benzodiazepine. Benzodiazepine, which one? Lorazepam, midazolam. Yeah. How much? 0.1 milligram per kg per dose. And repeat the dose. This is the same treatment that we give for, if you recall, febrile seizures here. Lorazepam, diazepam, midazolam. Okay. So in here what we're going to give is midazolam or lorazepam. We're going to give 0.1 milligram per kg per dose. Seizure is still persisting, not resolved. We shift over to phenytoin or fosphenytoin. Okay, how much is this given? 20 milligram per kg. Seizure still persisting. Phospheniton, then we go to valproate or leviracetam. Okay, this is going to be 20 to 40 milligram per kg. Not working. Stronger drugs then. Phenobarbital. A phenobarbital medication would be given 20 milligram per kg. So all of this up until phenobarbital is okay. It's for 20 to 40 minutes, and this is a normal management. If it persists after 20 minutes, we're going to call it a refractory seizure. A refractory seizure. So a refractory seizure will be dealt with continuous infusion. Continuous infusion of the drugs that we're already giving. So benzodiazepine, midazolam or lorazepam, continuous infusion. We're going to give continuous infusion of phenobarbital and strong anesthesia, thiopentone. If this doesn't work, we're going to give ketamine infusion or IVIG, and this is categorized as super refractory seizure. That covers these two topics. We're going to, I think, it's over an hour here. We'll cover the other, cerebral palsy and CNS infection, in the next video. Okay. So then keep revising, keep being brilliant.